Welcome to this presentation on the approach to a patient with hoarseness of voice. Hoarseness is a common symptom encountered in clinical practice and may result from a wide range of conditions, from simple viral laryngitis to serious diseases like laryngeal cancer. A systematic approach helps identify the underlying cause and ensures timely management. In this session, we will discuss the anatomy of voice production, common causes of hoarseness, history taking, examination, investigations, red flag signs, and management. By the end of this session, you should be able to define hoarseness, understand its common causes, take a focused history, perform a relevant examination, identify red flag symptoms, and plan appropriate investigations and management. These skills are important for both examinations and clinical practice. Hoarseness, also known as dysphonia, refers to an abnormal change in the quality, pitch, loudness, or effort of the voice. Normally, voice is produced when air from the lungs passes through the vocal cords, causing them to vibrate. Any condition affecting the vocal cords, larynx, nerves, or surrounding structures can alter voice production and lead to hoarseness. Inflammatory causes include acute and chronic laryngitis, upper respiratory tract infections, and gastroesophageal reflux disease. Functional causes occur due to voice misuse, overuse, or muscle tension dysphonia. Structural causes include vocal cord nodules, polyps, cysts, and Wenck's edema. Neoplastic causes include benign tumors and malignant lesions like laryngeal carcinoma. Neurological causes include recurrent laryngeal nerve palsy, Parkinson's disease, stroke, and other neuromuscular disorders. A useful approach is to classify causes as inflammatory, functional, structural, neoplastic, and neurological. When evaluating a patient with hoarseness, start by determining the onset. Ask whether the symptom developed suddenly or gradually. Next, assess the duration. Hoarseness lasting more than 3 to 4 weeks require further evaluation. Ask about associated symptoms like sore throat, cough, fever, dysphagia, odynophagia, breathlessness, stridor, hemoptysis, or weight loss. Inquire about voice use. Professional voice users like teachers, singers, and public speakers are at increased risk of voice disorders. Also, ask about smoking, alcohol intake, occupational exposure, previous surgeries, thyroid disease, neurological disorders, and current medications. Begin with a general examination. Assess nutritional status, vital signs, and any signs of respiratory distress. Inspect the neck for swelling, thyroid enlargement, scars, or lymphadenopathy. Perform a complete examination of the oral cavity, nose, pharynx, and ears. A focused neurological examination is important, particularly assessment of cranial nerves when vocal cord paralysis is suspected. Finally, visualization of larynx through indirect laryngoscopy or flexible nasolaryngoscopy is often essential to identify the cause. Now, investigations. The most important investigation is laryngoscopy, which allows direct visualization of the vocal cords and larynx. Stroboscopy may be used to assess vocal cord vibration and subtle abnormalities. CT scan or MRI of the neck is indicated when a mass lesion, vocal cord paralysis, or malignancy is suspected. Voice assessment may be performed in specialized centers, and if a suspicious lesion is identified, biopsy is required for definitive diagnosis. Now, management depends on the underlying cause. Inflammatory conditions like laryngitis are treated with hydration, voice rest, and management of contributing factors like reflux. Voice therapy and vocal hygiene are important for functional disorders and professional voice users. Structural lesions like nodules or polyps may require speech therapy or surgical intervention. Neurological causes require treatment of the underlying neurological condition, and malignant lesions require urgent referral to an ENT specialist and multidisciplinary management. Now, certain features should raise concern for the serious disease, and these include hoarseness lasting longer than 4 weeks, smoking history, alcohol abuse, age above 40 years, dysphagia, odynophagia, hemoptysis, unexplained weight loss, neck mass, and stridor. The presence of any of these features warrants urgent ENT assessment to exclude laryngeal cancer or other significant pathology. Hoarseness is a symptom rather than a diagnosis. A structured approach involving careful history, focused examination, laryngoscopic evaluation, and appropriate investigations help identify the cause effectively. Always remember the red flag sign as early recognition and referral can significantly improve the patient outcome. Thank you for watching.